our speaker for today. Hi, Dr. Sai.
Hi, this is Naoki Sai. I'm a practicing hepatologist working in Kailua, and I continue to learn from all the audience from their experience. So we are mutually learning with each other. Thank you to be here.
Thank you. Great. Thank you, Dr. Sai. And so humble as probably as the top expert in our islands, but thank you, Dr. Sai. Next up with our faculty is Dr. Dr. Don Taniguchi. Oh my gosh, I'm having a Monday. My forgiveness, Don.
No problem.
I
Hi,
give you a moment to
everyone.
introduce yourself. Thank you for joining us today.
Oh, yeah, no problem. Hi, everyone. I'm Dawn Taniguchi. I'm a primary care provider at Kakuakalihi Valley, and then I also work with JAPSOM. Thank you.
Great. Thank you so much. We do not seem to have Richard Smith with us, which is also on our faculty, or Dr. Reutman. But I am going to introduce the last of our faculty who's also presenting our case today, which is Hiromi Saito from Waikiki Health. Welcome, Hiromi, if you want to introduce yourself, and then I'm going to share the screen with your case presentation for today.
Okay, yes. Hi, my name is Hiromi. Nice to see you all again. I'm a pharmacist from Waikiki Health. Thank you for having me share this case. Today, what I'm expecting is to hear a lot from you all because I do feel I do feel frustration, and then I feel very confused when we see somebody like her. So, and then I don't think there's an answer or two. It's just I just wanted to make a noises and the waves for today for us to just come together to think about somebody like her. So this person is 20 years. I mean, in her 20s. I try to make it vague because she's one of us, future one of us. Partially where she's one of us. I don't know how to describe it. But so we might know her. We might. So I try to make it as vague. And then so she, gender identifies she, and then she's Asian. She has commercial insurance. And my primary question, before I go to primary question, I would like to go all the bottom. Can you share the bottom of the screen? All the way down, please. The reason that I wanted to talk about her today is that Waikiki House does not take work comp, but she came to us because she had an accidental needle stick. She works in a medical setting, and she had a accidental needle stick, and then she wanted to. She had to do some paperwork for work, and she also wanted to check and then make a just follow up of the event. But because of that, she was asked why she's still working uh, at the medical situation because she had to kind of expose to people that she has HPV positive. And then after the event, she felt like she was discriminated, and then also because she's going to the school, she had to have a hepatitis B vaccine, even though she has um, anti-core positive and all the blood tests that she knows that she doesn't need a vaccine, but the school admission didn't allow her to proceed without vaccine record. So going up to the case, can you move up again, please? So my question today is that if the guy she came and she asked me if she needs to treat happy. She didn't want to start the treatment because she has to pay for the copay. She has to pay for the blood test. She has to pay for ultrasound, this and that. That's why she hasn't been seen since 2019. So my question is, the guideline will be applied differently if a patient is a medical professional, one of us, and then, or I just dig in a little bit, but then I found this, it would be different if the patient worker's job is performing exposure-prone procedures. And what does it mean? I don't understand. And then also how do we discuss or any opinions about the vaccine record that required for hepatitis B vaccine patient like her? And then also how to handle, how can we help to navigate this experience of the stigma that she's getting from the coworkers, especially for the non-medical staff, managers or cashiers or front desks or billing or the HR. So she was having difficulty. So these are the test result, surface antigen positive, and then core antibody positive, and the surface antibody is negative. Because this is the reason, as we learned, she does not need a vaccine. And then, so blood test, please go down a little bit. She does not have any symptoms of cirrhosis. She does not have any other comorbidities, and she never used the substance or no alcohol smoking. And she has a family history because she transmitted the Hep B through the childbirth. And then this is the platelet count, liver enzyme, and hepatitis B E antibody is positive, and the E antigen negative, BE antibody positive. So DNA, when we found out 2018 was 171,000, but we did update it, and that was 90. And the Hep B vaccine is done, Hep C negative, HIV negative, APRI score 0.2, FIB4 0.33, and FibroScan F0, S0. And then she's taking birth control.
Okay, thank you so much. How many layers of things that are very interesting, including stigma, right? Before we get to recommendations, we want to open it up. Are there any questions about this person for Hiromi? Any clarifications or any background information that you want to hear more about or clarify from Hiromi before we get into recommendations from the faculty?
Oh, what is that medication for? Escais?
That's a birth control,
Oh, okay.
oral
So
birth control.
estrogen. Okay. Is that an estrogen product, right?
Yes.
Okay. And you say 0. Oh, okay. So that's 2 components. All right.
Anybody else have
Can
questions?
somebody scroll up? I thought I saw that patient was surface antigen
Positive.
positive and core antibody positive, but core antibody or surface antibody negative?
Yes.
Okay.
And
So that's why they're recommending her to get another vaccination, right?
Mm,
Or because she's
talk
not
about it.
positive, or has she had multiple series and she's still not converting?
I think that when school admission, they don't require the blood test result. Even though she tries to bring it down too, but she said the admin office said, we do need a vaccine record.
Did she actually get a DNA level at all?
Yes, she did. So 2018 was 171,000. And then after that, she didn't see anyone. And so we updated and that was 90.
90, only 90.
Yeah.
Oh, I see.
And
Okay.
Hiromi Chulapong had a question about her BMI.
Oh,
Do we
she's
know?
18.
18 BMI. Okay. Anybody else have questions? I have to agree with you, Angela. Very disappointing to hear that the medical professionals are still perpetuating stigma. Yes, Dr. Sai, that has been ongoing. Yes, this idea that somehow a healthcare professional can't be living with hepatitis B and still perform safely. So,
I have
all
a
right.
question.
Any other questions? Otherwise, Dr. Sai, can we start with you?
I
Yes.
heard the voice that somebody said that.
Oh, yes. I was just wondering with the lab results, and she was Hep B surface antigen negative, right? Does that because she's chronically infected and was infected at birth? Or can
That's
maybe
right.
someone talk through
You're
the
right.
patho? Okay.
You're right. And I was going to address that a little bit later. But first of all, I sent an article to both Heathers. They should have it, and we can post it later on. It is a policy made by the National Health Agency at United Kingdom, and that is probably the most comprehensive and up-to-date recommendation regarding this issue. And I will talk a little bit about that later on. But first of all, to answer the question someone asked about why did the university ask them to do a vaccine? It is a wrong perceptions because a person that has been naturally infected, which is in this case, any kind of vaccine doesn't work, and it should not be offered for a vaccination because a person is already exposed to hepatitis B virus, and hepatitis B virus in this person's system. And you cannot prevent by vaccinating these people because vaccination is only for prevention of infection. It doesn't help after the facts. So that is wrong for the university. They don't really accept or listen to my recommendation all the time. So sometimes I do write letters to help clarify that part. Now, a lot of time that I know in some institution, they would accept the serological report. Say, listen, this person has been exposed and had a core antibody, therefore there is no need for vaccination. And hopefully that will go through that. The problem in the United States is we don't have a public policy regarding medical profession who have chronic hepatitis B. And realistically and practically, my recommendation is pretty much based upon the United Kingdom's recommendation. Basically, if someone who is performing high-risk procedure, such as surgery, hemodialysis nurse, dental hygienist, dentist, phlebotomist, they have this possible use of needle that there could be an accidental poke to the recipient. The current thinking is to make sure these persons are treated and there's no DNA in the blood. And if they can prove that they don't have DNA in the blood, then they should be allowed to perform those procedures. Any medical profession who are not doing those risk or invasive procedure, you don't need to declare who you are, and you don't need to say to be treated or to suppress the virus at all because you don't have DNA. So that's, I think, make it quite easy to follow as a principle, protecting the person who had the problems and protecting the patient that they are going to be doing procedure with. And it's interesting that you mentioned this because Dr. Reutemann actually called me up several weeks ago because the whole institution was in big debate about another issue like your patients. So I sent her the UK recommendations, and apparently that calmed down everyone in the institution and then resolved the whole issue about it. So that's basically what I would say about this case. Hiromi, I think, number one, if she is going to be doing things that could be invasive or have possible needle exposure to other people, she should consider treating to get the DNA down. I mean, that's kind of for the purpose of protecting the patient.
Even though the DNA level is 90,
Yes. You don't want to, because if something happens and the DNA was 90,
and then
legal
if
and medical ramifications.
we did actually discuss about it, and I couldn't define for her what's the medical procedures that makes her draw a line because she didn't want to start the treatment. And then because she's concerned about the copay, she's a commercial insurance, and then the clinic, she came to the clinic, and because the place that she was working for didn't pay for, like, didn't apply for the work comp, so she had to pay for all the labs and then visits and stuff, and then she's concerned about the all the additional costs. So, and then also she, at this point of the science, that she might keep taking like 50, 60 years of the medication without not missing. And she was not thrilled to have that thoughts.
Well, it is going to be a tough decision. If she's not going into a profession that is medical care, then we don't really need to treat her. But if she is going into a medical profession that had a potential of transmitting the illness, I think that is not ethical, not to do everything you can to protect your patients. So that's the choice that she has to make. And of course, you can do everything you can to help her financially. I don't think you, with a level of a DNA such a low level, you need to keep doing the DNA levels. Because once you treat it, it will be gone. I mean, the drug that we have is so good. And the medications, entecavir is a generic drug that is covered by most insurance that I know of. So those are the, it is difficult for her, I think, but you have to let her know that if you want to be a medical professional, that is the standard that we have to uphold.
She was thrilled to see the viral load came down from 171,000 to 90. Right. And then also she was asking that, is there any change that she could make? Any medical professionals that is not apply for this guideline?
Well, in the US, there is no guideline, basically.
Oh, okay.
That's very vague. But if you want to ask for a guideline, it is the one that I just showed you.
Yeah, okay.
That has the best advice for the medical profession to follow. And I believe that is a very important thing to think about if you're doing, if it is not a risk for the people who you serve, I don't really care if they need treated or not. That would be a personal decision. When you have another component in that situation, the thing has to be responsible for that. And that is kind of what I think is important in her case. She can go for a medical profession that don't do those things, okay? Then that's fine.
What are those medical professions that don't do those things?
Well, if you're doing the
Examples.
consultations, you don't draw blood, you're not injecting, there's no needle or open wound process. Then I think, surgeon, during the surgery, it's easy for them to cut or needle themselves and needle the patients. So those are what we call invasive procedures. Dentists doing the denting, do the dental procedure. Dental hygienist who is cleaning people's teeth, and they have a lot of needle sharp object which can penetrate their finger and penetrate patients' tissues. There could be very rare occasion, but you just don't want to have that on board. I mean, I hope I make that clear, the point clear to you.
Yeah.
Yeah. I mean, you can use all the excuses you want, but the fundamental point is, are you posing a risk for the person you are providing care? That's the fundamental questions.
I also came with a different angle to discuss with her to think how she feels about. So I borrowed your line that no virus is the good virus. That's the only good virus. And even though the 90 came down a lot, and also she's engaged in a relationship, and she's taking the oral contraceptives. So I thought not only professionally, like we talked about the harm reduction, and then
But she should warn her partner about this.
yeah.
And checked screening first, and then they are not exposed, vaccinating.
Right. Yes. Yeah, we had that conversation as well. Yeah.
There's a question in the chat, Hiromi and Dr. Sai, would this affect her ability to remain in school or her health professional program?
She went back to school in August. So
the school let her in because even without the vaccine records?
no, she had to have a vaccine, so she did get vaccine.
Well,
I know she
you
had.
know how ridiculous this policy is?
Thank you for yes. Thank you for saying it out loud.
They're just following the protocol without understanding why it is the vaccine. Because I think the reason behind the vaccine proof for medical profession is, number one, to protect them from getting infected when they are in the medical profession. That's a number one issue. Number two, they forget about the person already have it. They should be really shown that they cannot transmit their disease to the person they are taking care of. Or at least choose one profession that don't have those invasive procedures.
But I feel like that's the part. The admission office is not somebody who understands the depth of the condition, I guess, and then just yes, check, and then okay.
But if she got through it, that's fine. But in the future, as long as she's not engaged in any intrusive procedure, she has no obligation to let anybody knows what her conditions is. Okay? And a job or any employer is not by law permitted to ask those questions if the person declined to answer them. But I think certain professions that, such as the hemodialysis unit, and if you are going to be a nurse working there, you know how bloody they could be when they are putting needles into the AV shunt. And so I think they are very clear policy in those units that I know of. And I agree with that. It's, you just cannot expose people who are sick on the dialysis unit to get another infection.
So Dr. Tsai, it's interesting on page 24 of the document, which folks, I did put the chat in. It says, at least for the UK, that in order for an healthcare worker who has hepatitis B, they would have to keep their HBV DNA at or below 200 international units per ml, regardless of their treatment status, in order to continue working. I just thought that was an interesting. They put that down.
Yeah. It
That's
was
outdated.
But the problem with that policy is that it's a one-time test. And you do know the DNA tends to fluctuate. That was my point.
Right.
So you never know at what point in time, if they are not on treatment, then it could be going up 1,000s one day. And then if you happen, it's, the chance is low, but it still could happen. But UK, they take a compromise position there because the rationale behind that is for 200 IU DNA to transmit the disease is very low, but it depends on what kind of needle, what kind of exposure you have. The hollow needle, the hollow needle when you're drawing the blood or you are injecting things, that could have a lot of virus in there. So I'm just getting a little bit more for the purpose of more responsible that I would treat because
Yeah.
But Hiromi, you can do this if you don't want to go to medicine wise. Keep checking her DNA. She had an option. Take the pills and then forget about the DNA.
Yeah.
Keep testing DNA from time to time.
Mm-hmm.
Particularly if she's going to go into, right now she's in school. She probably don't do those needle. I don't know if they do. I don't even know which branch of the medical profession she's getting into. But if she doesn't have those intrusive procedure during the training, she probably don't need to worry about it in terms of treatment. But she may want to check it from time to time as her disease status change.
So that was a question in the chat. Sorry, Hiromi. Angela was asking, how often should she be coming in to get for labs to monitor HBV DNA?
Well, it all depends on, I wouldn't say very often. If they are going into doing something they're going to be exposing to other people, I think I would check it at the time. Yeah, and then from time to time check it. I don't have a time frame that I can say it. I would say at least every 6 months or at least a year, just to see the trend of the DNA.
Because as you said, it can fluctuate. I mean, we only have two time points, but 90 versus 170,000 is quite a difference just in her 2 testing points.
Yeah. But that's already like 7 years ago. And then at the time, the situation is different. She didn't start the school yet. She didn't decide what profession she's going to. And then I also felt like I was wondering that if she was taking the medication, and then even though the work people knew the diagnosis, but if she said that I'm taking the medication, I'm managing it, I'm good, do you think the stigma part might be different?
No, she don't have to say anything about her illness at all.
Yeah, but because she tried to do the work comp, she was like, I should have not reported because now everybody's looking me differently, and the manager told.
No, she should not be required to report. It's not. That's the part I'm totally agree that you don't need to let people know.
She wanted to use the work comp part instead of So now that they said no, then because she couldn't write the incident report correctly, that's another thing. So that they rejected the work comp. So that's why she came to Waikiki Health and then using her own insurance. And then, yeah, so that's another thing.
Well, it come to the point of the legality, so I think I will not be able to give any advice. If there is a
But
legal,
it was very frustrating to hear that, oh, what she has to say. And then even though if she does, she was like, she asked me the same question like Angela said, that how often do I have to do the blood test? And then once we started the medication, we still want to monitor you. We still want to be this.
no, her level is so low and the medicine is so effective, you probably not necessarily keep checking it. The only reason I check when I start treating people, which is when they need to be treated, to make sure they are compliant in taking the medicine. And if she is conscientious of taking medicine, compliant, you don't really need to check it all the time.
Yeah. Thank you. I will talk to her again.
Okay.
Thank you, Hiromi.
Encourage
We have
her.
we have a couple more moments. Do anybody else have questions? We have one a little bit unrelated question, Dr. Sai, that I'll ask you while we're waiting. This is
Yes.
from Chulapong.
Yes.
His question was, do we need to give HPV vaccine for people that we're screening and the triple panel test result shows isolated anti-HBC? I think we talked about this a bit last week, but yeah.
No, the vaccine is not appropriate for people who has been exposed. If somebody has been exposed to hepatitis B, the B DNA is inside the host system already. It's like the vaccine is like a barrier to prevent something from outside to come in. But hepatitis B is already inside. You're putting a barrier in between. Doesn't make any sense because they're already starting to replicating within the cell, within the host system already. So vaccine is not going to stop them from coming in. And they are not going to be able to protect them from spreading between cells inside the hepatocytes. Always remember, vaccine is for prevention, not for treatment. Okay, and there may be some reason for patients who have transplant. There are patients who have hepatitis B get a transplant from a virus from the liver that is non-virus, and then they were controlling them with antiviral agent, so there's no recurrence. That will be a good time to give them vaccine to see if they can develop the antibody against the Hep B to preventing any virus from the blood reinfecting the liver. But if somebody's already have virus inside the liver, that's what the infection occur, doesn't make sense to give you vaccine to prevent them spreading into the liver. They're already inside. You are putting an alarm in a house that has been burglarized, so to speak. Does that make sense? We put alarm before the burglar come in, right? But the burglar is already inside the, chewing up your house, and you say, well, I'm going to put an alarm system in the front. It doesn't make sense. So to answer your question, Shanda, no, I think any vaccine is not going to be helpful for anybody who has been exposed.
Thank you.
Does anybody else have questions or comments about this very interesting and actually in a lot of ways sad situation that Hiromi brought as far as at least around some of the discrimination and misunderstanding around the vaccine? But any other thoughts or questions? I think I have one for Dr. Sai or the rest. How can we advocate when we hear about discrimination like this? Is there anything we can do? Or how can we uplift people that have maybe felt like they've received discrimination for living with hepatitis B? I know it's a very broad question, Dr. Sai. But do you have any thoughts on how can we continue to speak up for people and advocate for them, especially if something like this where unfortunately because she shared, now she feels like there's discrimination back. Any suggestions on how we can support and address this stigma?
Well, if she already reported to her colleague or her employer, then it's too late. But I would say first, you do not have to say that you're infected for any other reason than if you are engaging an intrusive procedure and you know you can put other people at risk, then you have to say, for instance, if she had a partner that she had, a relationship, she should let the person know that I have this and you should get protected. I mean, that's only, right to do that. But if you're applying for a job, the employer are not permitted by law to ask those questions, okay? And if they do, they are breaking the law, and you can take them out to a legal professions. I think, you don't want to, I don't think any employer asks those questions anymore that I know of, because there is this discrimination law that is very strong against those intrusive questions, except those conditions that I know dialysis units, because they are protecting their patients from getting exposure. So they are very careful about that. They even separate dialysis unit between B positive and B negative. If you know, that's all the hemodialysis units. They have to test the patients, and they are negative or they are positive is separate. They're separate total units, separate total nursing staff to take care of them. They are very serious because that is a big problem that they have in the past. So those are specific situations where they have to answer. But to answer your question, Heather, there must be some legal society or even the, what is that organization? Forgot. There's a national organization that fighting for people's rights. What's the name of it? I kind of forget about. It's a national organization that help people
I don't
deal
remember.
with
But
discrimination.
actually, what we were talking about the treatment, and then we try to if the financial is the burden, and then someplace like Federal Qualified Health Center are the place that she can ask for help, and then that can be a way to kind of break the barrier, overcome the barrier, and at the same time that well, I'm not really sure that helped her, but like everybody who works in the healthcare, I shared a little bit of my personal history. I lost my father in diabetes and the complications, so that is the reason that I'm very interested in diabetes care, so that if she's understanding the condition, she learns, and she might be able to be a great asset in the medical field as a profession, and so that could be her strength rather than obstacle. Oh, that's so sweet of you. So I'm not really sure. So that she said that she's gonna come back and then continue the care with us, and then hopefully we can be as a colleague in a big circle, and then I think we should I feel like we should keep empowering her and then
Yes,
working with her.
especially since she doesn't have primary care, and it's blessed that you provide primary care, right, Hiromi? So hopefully she will end up having a good experience with you all so that she can keep doing primary care with you. And a
Yeah.
couple last pieces, and then we'll transition, Dr. Sai.
Yeah.
People did share that maybe checking with the Legal Aid Society or ACLU might be an option.
It is the ACLU that I was trying to
That's what you're
remember.
trying to think of. Okay, yeah, because actually that I could see this being a civil liberties, potentially civil
Right,
liberties
right,
case. Yeah.
exactly.
Then Angela wondered if some of the same protection might extend to students. For
Yes.
example, saying that because you have to pass your rotation, you must participate in all elements of it, sometimes even
Mm.
invasive procedures. So that could be a sticking point. And then last question, Dr. Sai, what are the labs that you look at to see the evidence of a patient taking their Hep B treatment consistently? And when would you expect the patient to respond to treatment to the point of it being reflected in their lab work? So I'm not sure if you're going to be going over that in your talk. If you want to start there, if you want to answer that question first.
Yeah, I think I'll answer now. It's the DNA. The antiviral agent that we have is very powerful, very potent. So usually within a month or two, the virus will start to see, you should start to see the drop of the hepatitis B viral load. So that DNA is the key to say if somebody's taking the medicine or not.
Okay, well, that was a great transition into your talk, Dr. Sagas. Let me get your slides up. And we are blessed to hear about chronic hepatitis C treatment from Dr. Naoki Sai. Get his slides up here.
All right, so next slide. So just to give a statistic globally, there's so many people are still with hepatitis B in the global. In US, the estimate is about 1.5 or 1.2 million, which is based on the mostly enhanced studies. They are the number one cause of liver cancer and number 3 cause of deaths worldwide. So basically, that hepatitis B is still a global problem. WHO had come out to say we need to eliminate 2030, and the following 3 points is their goal, is to vaccinate 90% of the newborns and screen 100% of the blood supply and treat more than 80% of patients who are eligible to be treated. Next slide. So just to go through several, graph to show the different clinical course of an acute infections. So this is a graph of acute hepatitis B infection. I believe this graph has been shown by Dr. Reutemann last week. Basically, the first thing that would appear if you had an exposure is surface antigen, but in fact, before that is hepatitis B DNA should be there within a week. If they are going to establish an infection, you will see them. Then the surface antigen will come out at about the same time or a little bit earlier will be the hepatitis B E antigen. And then over time, if a host was able to fend it off, don't go, yeah. If the host can start a good immune control, then the surface antigen level will drop about 6 months. The anti-core antibody would appear initially as an IgM class globulin, and then become IgG class core antibody persistent. So you can see that blue line is persistently there. So a person could have had a positive core antibody, but negative surface antigen and a negative surface antibody. That's what they call window period. And that is, if you look at the graph between week 24 to week 32, roughly. It's a rough estimation. So during that window period of time, a person who have acute infection could have just core antibody without surface antigen or surface antibody. And later on, the surface antibody will come out. So you will see surface antibody positive and a core antibody positive, which is what the case that Hiromi presented. But she also had DNA that's didn't really clear. So the surface antigen remain positive on the next slide. That's called chronic infections. So the surface antigen, the core antibody will persist the anti-hepatitis B surface antibody may or may not show up. So you don't see that. But if they do transmit it through a very early childhood, then most people will proceed to have chronic infections. And the surface antigen positive and core antibody positive are the norm for a person with infection. Later on in life, a body would eventually develop a host immune system in some patients. Then you will see the anti-core antibody plus anti-B surface antibodies. So that is kind of the resolution part of the chronic infections. Next slide. And the third manifestation is somebody who have chronic infections, and they could be absolutely no symptoms, so they don't have hepatitis, but because they were exposed to chemotherapy or immunosuppressive therapy, then the virus will come out, become very active, and the enzyme will come up. And some of the time, even with antiviral therapy, the entecavir initiation here in day 60 still didn't help the patients, and the patient eventually died. This is a case of a woman who had breast cancer, receiving doxorubicin, the Taxols, and dexamethasone, and cyclophosphamide. So these are immunosuppressive treatment that can cause a reactivation, and that could cause mortality simply because the body's immune system is not able to protect the patient, and the patients continue to have very severe inflammation despite the virus was under control with antiviral therapy. So these are the sad case of immunotherapy that causes mortality because they underwent immunosuppressive therapy. I think we discussed that on the last session. So these are three major clinical courses of an individual who are exposed to hepatitis B. Next slide. Now, talking about isolated positive core antibodies, could be, like I mentioned earlier, they're just recovering from acute hepatitis B, and they lost the IgM, and the IgG starting to come out. And surface antibody and surface antigen just not ready to come out, or one is already disappearing. Or they could be exposed and develop immune control, but the current test is unable to detect hepatitis B surface antibody. And this person could be infection, but may not be, maybe on the way of developing immune control. Number three is there's a false positive core antibody person, and the patient may be having the high level of immunoglobulin that cross-react to the antibody of the core and show us a false positive. So this person is not infected. There's a misspelling here. Now, the number four is undetectable level of surface antigens because it's a low level viral stimulations. And however, their DNA level could be positive. This is what we call occult chronic hepatitis B. And that sometimes occur. And therefore, if you have a case who have core antibody positive, isolated, and negative surface antigen or surface antibody, one test to do is to do a DNA to see if they are chronically infected or not and had the potential of infecting other people. Next slide. So the current treatment option in the United States are these three agents: entecavir, tenofovir disoproxil fumarate, and tenofovir alafenamide. And they are all very effective treatments. And we will talk a little bit about the choice of the different medication. Next slide. And there is a lot of controversy about when to start treatments, even to this date. And this is an old slide and an old concept that if you look at a person's clinical natural histories of chronic hepatitis B infections, there is 2 periods of time shows very active liver disease, and that is in those 2 red the arrow that I point out here is that a patient who is in the immune clearance phase that usually are hepatitis E antigen positive, or they were in reactivation phase later on, they're usually E antigen negative, and they have high level of enzymes, they have moderate level of hepatitis B DNA. So those are the very treatment agreements among all the society's recommendation, meaning you have disease activity, then you should treat them. Some may argue, particularly in the first phase of immune clearance, that to wait a little bit longer before the host was able to control the virus on its own without treatments. So that was some argument in the past. Next slide. And these are on those patients who are not cirrhotic. But the new proposal nomenclature at this time, instead of going through the immune tolerance, immune active, resolution phase, I think it's easier to identify patients through these 4 different phases or 4 different stages of liver disease. E antigen positive chronic infections, which means they don't have disease activity, or E antigen positive chronic hepatitis. That means they have disease activity. And the same thing for E antigen negative patient of those 2 populations. Next slide. The current American societies of liver disease have the following guidelines. A person who do not have cirrhosis, if they are E positive and their liver enzyme is twice upper normal limits and their DNA is more than 20,000. If they are E antigen negative, then the ALT should be higher than 2 times upper limits of normal and a DNA more than 2,000. A person has shown to have cirrhosis, then treat all patients with positive DNA, regardless of ALT level. And for an upper limits of normal, the normal liver enzymes in their definition is for men is 30 and below, and for women is 19 and below. Next slide. So this current treatment guidelines showing that for those patients who are E positive but only infection without enzyme elevation, or E negative without enzyme elevation, and the reason they don't want to treat this group of people is based on the following reasons. They think there is no significant clinical outcome in small sample size and a short duration therapy in the past. And they were concerned about long-term therapy and the drug safety. And then there was a cost because associated with this long-term therapy, and which is reasonable, but I think this concern is getting less and less important nowadays. Next slide. The problem I have, or some of my colleagues have with the current ASD guideline is that using ALT as an index of treatment is not correct. It is an inflammatory surrogate, and they fluctuate over time. So it all depends on when you get a blood test. You can miss some patients. So there are many studies that have shown the following findings, and they are mostly surveillance studies, meaning people who are not being treated and being followed over a long time, that 75% of patients, when they are doing surveillance, which could be once a year or once 6 months, have normal ALT, and 37% of those only have an annual DNA testing, and 18% were treatment eligible but never been treated. So this kind of the problem we have with base the treatment guideline on the ALT level. And then the patient frequently transition between phases. They could be immune active and then become immune inactive and immune active again. And unless you are really following them very closely and they are compliant in following up with you, you can miss area where patients really meet the criteria of treatment. So it is very hard to discern between patients who have chronic infection or chronic hepatitis. It would be nice to know exactly the patient have and for how long and intervene when they become inflamed. But that is almost very unlikely. Next slide. So the traditional concept of what we call immune tolerant phase, which means a person have minimal or no inflammation or fibrosis in the liver and have very negligible risk of progression to cirrhosis by our traditional histological data. And so they are at very low risk for liver cancer. And the supporting evidence are shown here from a Hong Kong liver fibrosis study group. And about 48 out of 57 that they did, so a very small study, that they had persistent normal ALT remain in immune tolerant phase. And the disease progression was minimal. These are usually followed for about 5 years, sometimes to 10 years. The median age that they are following at the age 31, and the DNA level is very high in the 9.8 range. So this is kind of what the study have shown, that the fibrosis on the right-hand side, baseline, and then 5 years later, they don't really see much progression of the disease. These are studies that was done back in 2007. Next slide. Now, there are other studies which are shown here, which is more later part of the historical database, that fibrosis among e antigen positive patient with normal ALT, we're talking about the so-called IT immune tolerant patients, they do have significant number of people have significant fibrosis. About 20%, 22% of them have F2, 15% is type 0, but stage 1 fibrosis about 60%, and then there were advanced fibrosis in about 3.7%. In all, almost 26% have significant scar tissues when they were subject to biopsy. And this is from Stanford studies. The second one is a Hong Kong study where they look at patients who have, quote unquote, E positive, positive, ALT normal, and high level of DNA. They have shown that by doing FibroScan, they found that there were significant persons who have more advanced fibrosis, even in those patients who have ALT less than 1 or 1 to 2. We're talking about 10 to 20% of patients have advanced fibrosis. So there are evidence subsequently found out that if you do more diligent follow-up and more realistic biopsy-proven fibrosis staging, you are seeing some patients have the fibrosis already that cannot be told by just looking at the ALT level. Next slide. And there is high risk of liver cancer and death in those patients who are not treated. This is based on Korean studies. This one study shows the liver cancer in those patients who have IT immune tolerant, they are not treated, assume they are IT, or IA, which is immune active patients who are treated. Those patients who are not treated over a period of 10 years have a higher level of liver cancer comparing to those who are treated. And the death or transplantation needs the same thing as they shown in this 10-year follow-up studies. So that is a concern to many of us who are in the fields of treating hepatitis B, that we're beginning to understand that there was really need for us to look into the DNA as a marker rather than ALT as a marker. Next slide. We all know hepatitis B infections are incurable. They can be controlled, but they cannot be cured. The reason is because there are two forms of hepatitis B genome DNA that is incorporated into the host genome, either by forming a very stable and persistent DNA complex inside the hepatocyte nucleus, or they can actually integrate part of their DNA into the host genomes. And this setup helped the DNA hepatitis B to produce more virus, and they could also be mutagenic, that leads to liver cancer. And it's been shown over the years, many studies, that hepatitis B DNA integration into the host genome can trigger a tumor transformations. And so this is something that caught most of our attention, that maybe DNA is the one we need to really focus on rather than rely on informations. Next slide. In fact, the majority of people nowadays, at least in the United States, that come to the point where they need liver transplant is because they have liver cancer. So that become really a true endpoint for us treating hepatitis B patients. This is a very graphic cartoon that depicts the two forms of the DNA. In the blue circle, the light blue circle, that's the nucleus of the hepatocytes, where you have two forms of DNA. One is integration DNA and one is cccDNA. And once you integrate into the DNA, which can come also from cccDNA itself, because they are there all the time, you can transform the hepatocyte into a malignant cells. And that is pretty much proven nowadays, that if you let the hepatitis B DNA running around without suppressing them, then you give them a chance for integrations and you give them a chance of liver cancer. Next slide. So we have several facts here about liver cancer and hepatitis B infection. As I shown earlier, is the insertion near the tumor promoter or suppression gene by the DNA. They can do frame shift mutation. They can get this dysregulation of protein synthesis. All this mechanism leads to the cell to turn into cancer. And they don't have to go through cirrhosis, and they don't have to have inflammations. That's the scary part of this virus. Next slide. So, can we prevent liver cancer? Probably reduce, but not totally prevent. And the first evidence was shown in a 2004 study from Asia, that they used lamivudine, which is the first generation hepatitis B antiviral agents. They were found to be able to reduce mortality and risk of liver cancer in the group of patients who had advanced liver disease, advanced fibrosis and cirrhosis. So they also found that total suppression of DNA have the best percentage reductions in the study. Next slide. And this is a long-term treatment study reducing the HBV DNA integrations. Remember, the HBV DNA integrations are the key of liver cancer development. So this is a Chinese study just published a year ago, that after 78 weeks of antiviral therapy, in this case, entecavir, the hepatitis B integration expression decreased by 12.25 folds from the baseline. So by suppressing the virus itself, really reduce the integration itself. And it is believed that antiviral therapy can reduce, but not eliminate hepatitis B integration over 260 weeks of therapy. So there still has some risk, but risk was reduced. So I think that's kind of based that many people use and start to think, have a little bit shifting in terms of when to treat these patients. Next slide. So the recent nucleoside treatment that prevent liver cancer has been shown. There's some controversy about comparing to entecavir and the tenofovir, that which can improve or reduce the liver cancer more effectively than the other. It's controversy. It's very difficult. But one study did show that tenofovir is better than entecavir in preventing recurrence. So that is, somebody have cancer, they got treated, but they were on treatment with just 2 medicines, and one seemed to be a little bit better. But that is not important. The important thing is, what should we use to choose the treatment? If we decided the treatment is indicated, number one, you really want to look at bone and renal toxicity. Particularly the person who had bone thinning problems. They were having other chronic disease that affecting the kidney. I think you should work toward using a medication that have least of these side effects. Age and need for renal dosing adjustment is another issue that we have to think about. But most important, and I think you all have the experience, that is the insurance coverage and the cost. And that would drive a lot of people into choosing which medication to use. Next slide. So the new treatment paradigm, I just want to summarize. The treatment initiation for all patients with ALT that's not normal and the DNA is more than 2,000 international units. This is a new kind of consensus guideline that comes from Europe, and that was published in 2025. Those patients who are in the so-called gray zones, we should obtain a fibrosis score, particularly FibroScan will be very helpful. And if the fibrosis score is 2 and above, I think I would treat, no matter how high the ALT level or how low the ALT level. And all patients with cirrhosis with F4 staging, I would treat them if their DNA is positive. Anybody who undergo immunosuppressions with HBV exposure, regardless of HBV DNA or ALT level, that need to be treated prophylactically. Except the one that we discussed about low-risk patient populations, low-risk drug usage. Patients who are co-infected with HIV or HCV, I think we all know we need to treat them. And family history of liver cancer or cirrhosis due to chronic hepatitis B is one thing that people are getting into consideration for treating them early. And then if there are evidence of comorbid conditions such as MASH or fatty liver disease or type 2 diabetes, because both of them has been connected with increasing cancer, particularly in the liver. So these are high-risk population that you have to put into your consideration if you want to start treatments. Next slide. That's it. That's a short presentations. I think there are many questions.
So the first one is if we can measure the HbSAg level in this patient and the result shows less than 100 international units per ml, which correlates with the cccDNA, is silence or inactive? Oh my gosh, I'm sorry, Dr. Tsai, I'm not reading this very well.
Well, I think the question, let me clarify. I think the question is, if the person have very low level hepatitis B surface antigen, can we wait until the DNA go up to 200? I think it's 2000 IU. And here's the answer. I think the reason of using quantified hepatitis B surface antigen is that they think that these people can have a much better chance of hepatitis B surface antigen seroconversion. And they are the one they are advocates to treat these people because you are closer to the point where they would do seroconversion, because the endpoint, in my view, should not be e antigen become e antibody, should not be DNA just negative. They had to be hepatitis B surface antigen seroconverted to hepatitis B surface antibody. That is the goal of the treatments. So measuring, because there was a lot of argument about using surface antigen level to determine when to stop therapy or when to start therapy. But I think if you're just looking at the surface antigen, their presence, if they are present, if the surface antigens are around, they always have a chance of reactivation. And for me, if you want to treat them, the medicine is very safe nowadays. And I think the price cost is going to go further down. I would like to treat somebody to the point where they are surface antigen seroconversion. Therefore, the surface antigen titer is not very helpful in terms of me either starting therapy or stopping therapy, because I really want to see the surface antigen seroconversions. It would be nice if you have a surface antigen 100, you tell patient that we should continue to treat, and your chance of seroconversion in the short term is very high. But that is something you can discuss, but I don't usually use a surface antigen level. I'm sure many people would argue that they should, but I don't know how to use it. That's my concern. If you're doing a study, fine. You want to well define where to stop, where to start. That's okay. It's a study instrument, but in the daily practice, I don't see how much usage of that measurement.
Thank you. And we do appreciate you coming in all the way in from Thailand with that question. Next up, I have from Hiromi. If the patient has been diagnosed, treated, what about with MASH or alcohol use disorder with fibrosis greater than F2?
Yes, I think then you have to consider there is two disease process affecting the liver. It's not just one. And so if the hepatitis B under control with treatment and their DNA undetectable, even though they are still surface antigen positive, I would treat them for the MASH. MASH and a B combined increase the risk of cancer.
What about the alcohol? Sorry for the camera that it doesn't work somehow. What about the alcohol use disorder?
Yeah, same thing, but it doesn't make sense for the person continue to drink, and you're treating their fatty liver. They're going to continue to feed in the fatty. So the first job is to make sure they stop.
The alcohol use disorder. The last one, like the treatment, that if they're comorbidity for diabetes, then that's going to be a new category to more tip for the treatment. But if patient is Hep B and the viral load is detectable, and then patient have an alcohol use disorder and affecting negatively for the liver, but questionable of the reliability of the adherence, what would be your recommendation?
Recommendation regarding treatment hepatitis B, treatment for diabetes, or treatment?
Yeah, treatment for the hepatitis B.
I would treat them too, because that's one thing that you can control very easily.
Thank you.
Hi, anybody else have questions? Oh, wait, we have one more. What medication is appropriate for an elderly patient, 78 years old, who has hepatitis B and cirrhosis with CKD, stage 3A?
Well, I think I would, if the patient has never been exposed to antiviral therapy and there is no, if you can find out if they don't have exposure to other antiviral in the past, I will use entecavir. Entecavir is pretty safe. And CKD3A, you don't need to do dose adjustment. Three A is that their GFR is about 40 something and about, right? Between 40 and 50. You might remember 45. Yeah, that's fine. You don't have to do reduction. It's only below 40, then you should start worry about it. And that means you have to go every other day.
Thank you. I'm trying to see if there's anybody else that I've missed. I think most of the rest of this was around, we're having some problems with the slides. I don't see any other questions in the chat, but want to open it up if anybody else had questions for Dr. Tsai. Next week, we are having Dr. Tran talk about cancer surveillance and liver transplant. So there'll be a nice follow-up to today. But yes, any other thoughts or questions before we say aloha? Yes, please, Leilani, feel free to come off mute and ask.
Thank you. Hi, Dr. Tsai.
Yes.
I had a question about the use of the Know HBV app that I've been looking at for probably the last year since the Liver Summit last year. And I will kind of just occasionally plug information in to just be like, okay, who needs treatment? Is that using the AASLD? Is that pretty accurate to these 2025 European guidelines, or is that now kind of obsolete?
Yeah, and actually AASLD's guideline is the last one published for 2018. They have
Yes.
not been updated. They did try this last year. They were talking a lot of time, and eventually when they come out with a consensus report in a draft, it was published and withdrawn. There's a lot of discussion, a lot of disagreement, even among the expert. So
Okay.
this hepatitis B treatment is really very fluid. And I believe most people in my field are getting to word. Just don't, if you have a chance to treat them to suppress the virus, it's probably the way to go. I use 2000, which goes, that's I think the European consensus that was just published this year. They're using, doesn't matter, don't worry about ALT, just look at the DNA level. If they have cirrhosis, then you treat them, even DNA is just positive. So that's kind of the current guideline that I think is most up to date. But I believe AASLD is getting toward that endpoint. They're still getting to that, but there is some other people are still holding up in the panel. And the panel is not just the hepatology. There were other disciplines that is involved in that, and some of them were just a hold up purist of the old dictum that they have in the beginning. The older concept of treating them when they are inflamed is based on several concerns. One is that they don't know how safe this medicine is over time. And I think we have more than 30 years of experience, particularly with entecavir. It's not really showing any significant signals after long-term use. And number two, the cost is coming down. And I was going to ask Hiromi about this patient of her who is in the medical profession thinking about the cost. I think the cost, if you have an insurance coverage, should be very, very low nowadays. So that's kind of the main concern they have. And they say that if you don't treat them, they will get better. That is more in terms of information. But they didn't count over long-term the risk of liver cancer. And then in the last few years, more and more data come out is that that DNA integration is the key of cancer. And nowadays, what we are facing with is not decompensated liver disease, at least in the US, but more liver cancer. And that is the most common reason why a person with chronic hepatitis B that need transplant. So I think our goal should be more into that endpoint prevention rather than just the information itself.
Thank you. And then if there's time, I did have one more question because it feels like the 2025 guidelines you showed us to determine if we treat or not, that is very sensitive to how we stage fibrosis. And so I know we had the lecture on using fibroscans over FIB4 or APRI. As primary care providers, should we really push for getting the FibroScan over doing an APRI or a FIB4?
I think I'll do a FIB4 first. And if there were, less than 1.3, you probably don't need to worry because they are very good in terms of fibrosis, very low level. But if you have a higher level of FIB4, then you start to worry about that you're missing something, and that's when the FibroScan could be helpful.
Thank you so much. Very helpful.
Now, the other thing that if you really have a hard time getting the FibroScan, there's a serology test you can use called ELF, called Enhanced Liver Fibrosis, and which is it's a blood test, but it's a proprietary owned test. So you have to, I think there's some expense related to that ordering of the test, but they are very accurate, pretty good accurate, compatible with the FibroScan.
Good. Thank you, Dr. Tsai. I think we have time for one last question, which was in the chat. By the way, folks, your link to your survey to get your continuing education units is also in the chat. But the question is there an age when you would stop treating for hepatitis B, Dr. Tsai?
Well, when you mentioned about age, I'm very sensitive to that because I'm very old, if you see me. If they are indicated for treatment, I will continue to treat them. I think there shouldn't be an age limit unless the people say, forget about it, I'm not going to do anything about it. So if you're going to stop a person on treatment, you probably should monitor them at least for a year for reactivations, because it's a danger of stopping treatment if they are not achieving the surface antigen seroconversions. So that will be the only thing I would warn you. You can consider stopping the therapy. That's fine if they're 85 years old or 82 years old. But you want to be sure they don't get reactivation if you stopping the treatment. That's always a risk.
Thank you, Dr. Tsai. And you're not old, but I appreciate you. We do really appreciate everybody today, and that was a very interesting case presentation by Hiromi, and actually a very easy to understand treatment from Dr. Tsai. So next week we will have Dr. Tran again talking about cancer surveillance. You heard Dr. Tsai talk about how incredibly important cancer surveillance is, and that treating to prevent cancer, right? Dr. Tsai is a goal. So we'll be doing that as well as hearing from him about liver transplant, and we have a case already that is linked to liver transplant. We still, however, have a couple of case presentations later in the series that are still open. So if you are interested, please don't hesitate to reach out. Again, please fill out the survey. And we're so grateful for all of you for participating. We are halfway through our hepatitis B echo. We have 4 more weeks and look forward to seeing you next week again to focus on cancer surveillance and liver transplant. Thank you, everybody. Thank you, Dr. Tsai, Hiromi, Dr. Taniguchi, and all of our faculty. Please take care, and thanks for helping make Hawaii hep-free.
Thank you, Hiromi. That was
Thank you very much.
That's a very good case. Yeah,
it really was. Yes. All right, faculty, I'll see you in a couple of minutes if you don't mind, in a quick debrief. Thanks.
Okay, thank you.
Okay.